So last class we were discussing about the stainless steel crowns, the indications of the stainless steel crowns, what are all the contraindications of stainless steel crowns, what is the classification of stainless steel crowns. Now we'll come to the clinical procedures. So these are all the steps how you are supposed to do a stainless steel crown. So first is the evaluate the pre-operative occlusion, then administration of LA, placement of the rubber dam, then you should select the crown appropriate for the tooth, then the tooth preparation, evaluation of the tooth preparation, crown adaptation, finishing and polishing of the crown, cementation, and the post-operative instructions. So now coming to the pre-operative evaluation. So for evaluating the pre-operatively, first you should have a diagnostic cast. So diagnostic cast should be at occlusion. So you need to see whether the what is the occlusion. Okay, before placing the crown, what is the occlusion to evaluate? For that, you require a diagnostic cast. Then you should check for the midline. Midline has to be marked in the cast. Then the cuspal fossa relationship bilaterally. What is the canine relationship bilaterally? Then extrusion of the opposite tooth, then the mesial rifting of the adjacent tooth. So all those things you can get it in the diagnostic cast. So what that is the first thing. Now next, when you are giving an crown, first you need to anesthetize the area to reduce the discomfort during the subgingival preparation, because whenever you are doing a preparation, the tissues are involved. Sometimes the tissues, a little bit tissue damage can occur. So in order to reduce the discomfort, you can give a infiltration. LA infiltration can be given. Then placement of the rubber dam, that is fantastic if you can able to isolate the rubber dam, because to protect the surrounding tissues, to improve the visibility, to improve the efficiency, and to manage the better management of the behavior. Now coming to the crown selection. So there are mainly three considerations for the selection of the crown. One is the mesodistal diameter of the crown tooth, then the light resistance on seating, then the proper occlusal height. So these are the three considerations you need to consider when you are giving a when you are selecting the crowns. So before preparation with the Boyle's gauge, you need to check for the mesodistal width. Then the same way after the preparation also you can do a trial and error. Then the smallest crowns are selected, because when you are taking the mesodistal width of the tooth, one size smaller to the mesodistal width of the tooth you will be selecting for the placement of the crown. Then the friction to be felt when the crown slips gingivally, that snap fit, it should literally cover the tooth, and that snap fit should be there. So coming to the tooth preparation, the aim of the tooth preparation is to provide the sufficient space for the stainless steel crown to stay on the arch, to remove the complete caries from the tooth, and to have a sufficient tooth for the retention of the crown, because you cannot just right, left, center, you cannot just cut the crown. So you should have a sufficient tooth bulk should be there for the retention of the crown. Now coming to the occlusal reduction, Humphrey in 1950, he said that all sides are reduced. The proximal sides, buccal side, lingual side, he has told like that. So all sides are reduced and retain the crown structure. But in 1966, Rapp, what he has done is occlusal reduction to be kept at least 4 mm from the gingival margin. From the gingival margin, the occlusal, after the occlusal reduction, there should be 4 mm clearance. I mean, 4 mm should be there. The tooth should be 4 mm. And in Ming and Bennett in 1968, what is that they have told us, the uniform occlusal reduction of 1 to 1.5 mm should be done. This is the one which we are following. That is minimum of 1 to 1.5 mm occlusal reduction should be there. Okay. So this is how you do an occlusal reduction. You need to see you need to follow the cuspal inclines. Okay, you need to follow the cuspal inclines, and you are supposed to do an occlusal reduction. And you can see here, it should be 1 to 1.5 mm reduction has been done. Okay, so you can see the clearance here, 1 to 1.5 mm clearance is there. So how will you evaluate the occlusal reduction? So the occlusal reduction can be evaluated by placing a back sheet. So you can keep a back sheet and ask the patient to bite. So if the imprints of the upper tooth is not coming, means you got a proper occlusal reduction is proper. Then visual examination can be done. Use an explorer and move on the surface of the tooth which you have prepared. If the explorer moves freely, which means that there is sufficient space for the, 1.5 mm, 1 to 1.5 mm, you have reduced it. Then next thing what you need to see in occlusional reduction is the preservation of the occlusal anatomy. So the crown retention, the crown retentive potential will be more if you are preserving the occlusal anatomy. Then the less chances of pulpal exposure and the preservation of the tooth structure. Basically, when you are giving a crown, means you are trying to preserve the tooth structure. Then now we have done the occlusal reduction. Next comes the proximal reduction. So the proximal reduction, ideally what you can do is either you can place a separator or you can place a wedge proximally. Then use 69 L burr or a 169 L burr, and it's moved buccolingually. Just you have to start from the buccal, and with one swipe it has to go to the lingual. You cannot keep on moving the buccal and lingual side for so many times. So we'll say it's like a proximal slicing. You're just slicing it. One shot, you're slicing it. So being at the marginal ridge and at a 10-degree convergence towards the occlusal surface, a little bit of convergence you can give. Okay. Do not over taper. You can see in the diagram, you cannot over taper like this. Okay. And in a stainless steel crown, the margins are feather edge margins. Okay. The finished lines are feather edge. There should not be shoulder preparation, should not be there. It should be a feather edge preparation. So this is how you do a proximal preparation, and this is how it looks after the preparation. So why I am saying to take it in one swipe is, if you are swiping it a lot of times, there will be a formation of a shoulder or a finished line preparation will be there. So that is not required in the stainless steel preparation. Then the contact with the adjacent teeth must be broken gingivally and buccolingually. So the entire contact has to be broken. In the previous diagram, I have shown that the entire contact has been broken. There is no contact here. So that should be there. Then the proximal slices converge slightly towards the occlusal and the lingual side. So here the proximal, you can see the proper slices just parallel to each other. It should be literally parallel with the tooth. So this is the improper one. You can see that there's an angulation is there. So the proximal slice must be extended below the gingival crust or to avoid leaving a ledge. So this is what is called as a ledge. So, and avoid to leading a ledge, you can extend below the gingival crust. So the ledge can be caused by the obstructed crown may cause obstructed crown placement, popping out of the crown, and it's a stress area, which ultimately is bad for the tooth. Now, how will you evaluate the proximal reduction? Pass the explorer through the proximal areas and check for the broken contacts. Now coming to the buccal and lingual reduction. So the natural undercuts will give a proper retention. So ideally, the buccal and lingual reduction are not much required. But in some cases, especially in the upper primary, first primary molar and the lower first primary molar, there is a buccal bulge is there. Sometimes that will inter the placement of the crown. So you can slowly reshape the bulge, or a little bit of buccal reduction can be done, especially if there is a large bulge is there. Then according to Pinkham, the large mesoliqual bulge, both buccal and lingual reduction can be done, but not much. Not much of reduction should be there. So evaluation of the tooth preparation, how can you evaluate whether you have done a good tooth preparation? Is occlusal clearance is from 1 to 2 mm. Then the proximal slice coverage towards the occlusal and lingual. Then the exposure can be placed between the prepared tooth and the proximal tooth. Then the buccal and lingual surfaces, if required, can reduce 0.5 mm with the feather edge margin. Buccal and lingual surface coverage slightly towards the occlusal, and all the line angles and point angles should be rounded. If it is sharp, if the line angles and point angles are sharp, that will act as a stress point for the tooth. Now, next comes the selection of the crown. The crown can be selected before or after the preparation. So the crown should have a tight snap fit. Then the restore the original contour of the occlusal and occlusal anatomy. Choose smallest size that fits well. And usually the 4 and 5 sizes are most commonly used. The three main considerations when you are selecting the crown is adequate mesodistal width, light resistance on seating, and the proper occlusal height. Then the crown larger, the tooth should be adapted. Then especially the when the gingival part of the crown is trimmed and crimped. Too large crown will rotate on the tooth preparation. So ideally, you have to select the apt size of the crown. Now next comes you have selected the crown now. Now next comes this crown adaptations. So try the crown onto the teeth. Ideally, when you are placing the crown, you have to place from lingual to buccal. So you have to place from lingually to buccally. Okay. Then mark the scratch line. Means if there is an extension is there, mark it. Then cut 1 mm below if it is with the scissors, or if you are trimming with that burr, you can trim up to the level what you have marked. Then if blanching is seen, blanching is nothing but if there is an overextension of the crown is there, there will be whitening of the gingiva will be there. So if blanching is seen, again remove the crown and again retrim and recontour the crown. Then if it doesn't sit completely, reduce little bit of occlusal surface. So that is how you adapt the crown onto the tooth. Then next is the contouring of the crown. The contouring is nothing but the gingival contouring. You are adapting the crown more towards the gingivally. So the buccal and gingival contour of the ears are always in a smile shape. Means the contouring is in the smile shape. The smile is what you make. That's how it is. Then the buccal gingival contour of the D. This is the first primary molar. Is the reverses or the S shape or stretched out S. This is the gingival contour. The reverses contour is there. Then the proximal contours are always in the frown. Frown means sad face. The proximal contour are in the frown shape. Okay. Then the lingual contours of all molars are always in the smiley. Then the contouring, crown contouring. The crown contouring pliers, ideally what you use is the ball and socket plier, the Jordan plier, and the Johnson's pliers. Then used for the initial contouring of the middle third, that is the bellying effect. Then next is the crimping of the crown. So you have to invert movement of the margins. The extended margins you have to crimp inside, so that the margins of the crown will be towards the tooth. Okay. So after crimping, you should get a snap fit, or it should snap into the position with a firm finger pressure. Then how will you evaluate the crimping? The evaluation can be done, check out with the explorers. If the margins are open, recrimp it. If overextended, start again and again place it. Then the blanching should not be there. Okay. Then if you are taking a bite wing radiograph, it should have a proper occlusion. Then tight fit of the crown aids in the mechanical retention, protection of cement from exposure to oral fluids, and the maintenance of gingival health. Then you have to go for a final trial. The resistance in seating without blanching, check for all the ledges. If there is any ledge, you need to reduce the ledge. Then resistance of seating with blanching. If there is blanching present, then the crown too wide or crown too long, check for that. Then trim it. Then tissue. If the tissue is caught in the margins, that also can lead to blanching. Then the finishing and the polishing of the crown. If the crowns are unpolished, accumulation of plaque and gingiva will be there. So you can use a green stone to get a knife edge finish cervically. Use a rubber wheel to smoothen all the margins. Wire brush to polish the entire crown, and rods to give a final luster. Then burst shaving, that is the spun inside the crown, means because sometimes there will be, when you are trimming, a little bit of spuns will be there inside the crown. So you can do that, you can remove that. Then you can use the wheel burr which runs slowly with a light brush movement towards the center of the crown, so that that entire crown will have a good margins. Then allow the metal closer to the tooth without reducing the crown height. Now, the Sperring in 1984, he has told his principle of crown fit. So, view from the proximal surface, the buccolingual surface converge occlusally. When you see from the proximal side, the buccal and the lingual surface of the crown should converge occlusally. Then any point above the greater diameter that is visible. Then any point below the greatest diameter is non-visible clinically. Then the principle 2, what he's told is correct contours of buccal and lingual gingival margins of the crown to gingival tissue. If the margins are correct, means the buccal and lingual gingival margins of the crown to tissue is the proper. Then the margins apical to the greater diameter will have a good adaptation. Now next is the crown cementations. The crown and the tooth has to be cleaned. If you are placing it for a vital teeth, apply a cavity varnish and then apply the crown. Place the crown. The common cements what you use is you can use GICs, polycarboxylate, zinc phosphate, silicates, all the cement, but most commonly used is type 1 glass ionomer cement is commonly used for cementation. Then for the crown cementation, place 2 inch 2 inch gauze posteriorly to the teeth. Then the tooth and the crown is cleaned. Isolation is mandatory. Apply Vaseline over the Vaseline to the contact areas. Then mix luting cement till 1.5 stir is formed. Then the placement of the cement in the crown should be approximately 2/3 should be filled. All the inner surface of the crown should be covered with the cement. Then seat the crown from the buccal to lingual. Lingual to buccal. Then the cement should be expressed out, or the flush should come out. The excess cement has to come out and asked to chew in the centric occlusion. Then the excessive cement should be removed with an explorer or a scaler tip. The excessive cement you can see in the diagram. Then the floss smooth buccal and lingual so that any excess cement can be removed. Then support the mandible during the procedure. Coming to the clinical evaluation of the crown and its margins are smooth and polished, properly adapted to the prepared tooth. The proximal contacts are established properly. Then the crown is in the proper occlusion. Check for that. Then the crown margins extended 0 to 1 mm into the gingival crevice. Excess of cement is removed completely. So this is how we evaluate. And radiographic evaluation, the crown margin should be adapted to the proximal surface. They should not be too long. The proximal contours are well reproduced. Then post-operative instructions, at least 1 hour, avoid sticky foods, hard candies, chewing on ice, popcorn, etc., etc. So ideally 1 hour, don't bite from that particular side. Then the clinical modifications of stainless steel crowns: adjacent stainless steel crown with amalgam restoration, adjacent stainless steel crown with the arch length loss, undersized crowns, oversized crowns, undersized crowns, then deep subgingival caries and open contacts. Coming to the adjacent crown. Adjacent crown means if you want to do a crown on both the tooth together, both means adjacent tooth. Like say for example, you want to give a crown for 7.4 and 7.5. So both the crowns should be placed at the same time. Then first the posterior most is prepared first, then the crown adjacent over it and fitted into the occlusion. Then the crown direction of the adjacent tooth is done. Then for broad contacts, use a hoe plier, because a hoe plier you can crush the crown a little bit so that you are able to place the size crown which you have selected. Then the crown preparation is completed. The stainless steel crown adjustments are made. Then the stainless steel crowns are removed and the cavity preparation is complete. Then the SCC is placed and restoration is done, and the SCC cementation is done. That is if with an amalgam restoration, means adjacent tooth has a restoration. So first crown preparation has to be done. SSC adjustments has to be done. SSC crown removed and the cavity preparation is done. So you will have a direct access to the cavity. Then adjacent tooth with an arch length loss. Means if the arch length is lost, okay, the crown may not be prepared at the same time. So more reduction with the mesodistal dimension is required. So the flattening the mesial and distal side. So I told it's already pre-contoured, so you can flatten it and then place it. Undersized and oversized crown. So due to the long-standing mesial and distal caries, what we can do is, if the crown size is less, what you can do is you can make a V-shaped cut on the buccal surface of the, from gingival to the occlusal surface. Then the cut edges are reapproximated to overlap on one another, so that the size of the crown is reduced. Then the crown is tried on the tooth, and the amount of overlap necessary is marked. Then the overlapped edges are then spot welded, then again nicely polished, and again you can replace it. Okay, this is how an undersized crown and oversized crown is done. Okay, you can see in the diagram, like it's cut, then it's been taken, both the sides have been taken and overlapped. Then you have done a spot welding is done. Then you are polishing the area. Then oversized tooth and undersized crown. The tooth is big and the crown is oversized tooth, and the undersized crown is small. So try the crown on the tooth, then make again same way, make a V cut on buccal and lingual side of if needed. Then try the crown again, then place an orthodontic band over the cut what you have made from the lingual aspect, then spot weld it and again polish it. Then oversized tooth and undersized crown, use a 114 plier to adapt the band, stretch the band wherever it is adapted to the tooth, then reposition the stretch and the band and spot weld it and finish it and polish it. So this is how the crown look after, if the tooth is oversized and the crown is undersized. So you are making the crown big. Then deep subgingival caries. If there is a deep subgingival caries, what we can do is you can take a small band and overextend. Means after the preparation of the crown, you can weld the band where the overextension is there and nicely reposition it. Next is the open contacts. So leads to the foot packing, plaque retention, and gingivitis. So the larger crowns are selected. Okay, and the interproximal contour exaggerated with 112 plier or addition of a solder interproximally can be done. So the causes of failure of Sse is inadequate tooth preparation, inadequate crown contouring or crimping, then inappropriate establishment of the occlusion, inappropriate cementation, the pulp therapy treatment is failed, then the recurrent caries or an improper contact, then the crown aberration on the occlusal surface. So these are the causes of failure of stainless steel crowns. Then the common errors what you can see in the preparation is the lack of featherage, the failure to round all the internal line angles and point angles, incorrect crown size, excessive reduction of the tooth, and formation of the ledge. So next, the problem, if you have not done a proper preparation, the major problem what the child develops is the accumulation of the plaque. Again, it will lead to gingivitis. So this ends the preparation of. So this ends the preparation of stainless steel crowns for the posterior tooth.